I finally figured out how to snap a little screw it to the camera and then put the whole tripod rather than trying to camera. I mean, like, and she went in and out.
I've probably seen y'all if I'm walking down there. If I'm good about my walking. Better about my walking. Birthday and she was just thrilled. But yeah, it was like, we realized that yeah. She was got a strong will. She could do it. And I think I'm working on a press release for you.
I'll just say that.
Right. This is on our calendar for October. We put all the guys want to get on a calendar.
So we can start on time. Take it away from here.
Okay, well, I appreciate it. This all stemmed from a case I think we had probably this spring of a young lady that came in after her pregnancy with some heart failure symptoms and had her echo showing her heart function was down in the mild range, and there was a lot of questions on 2 North about what actually was peripartum or postpartum cardiomyopathy. Unfortunately, I can't remember the lady's name. I was going to look up to see what actually happened with her, but I don't know the details, and I don't actually think she followed up with me, to be honest. It's fortunately a very rare disorder, so there's not a whole lot out there about it, so it's going to be a very kind of generalized talk about what actually it is and kind of the therapies that are coming up on it. Feel free to ask any questions during the time. It's a pretty short talk. But basically the definition is, in the Heart Failure Society, is it's an idiopathic, meaning we don't know what's causing it, cardiomyopathy or weakening of the heart. And it's usually at the end of pregnancy or in the first few months following delivery. And you have to look for other causes, obviously, to see if there's something else that would have caused the cardiomyopathy or weakening the heart. If none else are found, then you can assume it's related to the pregnancy. So this is this diagnosis of exclusion. You generally will see that the LV function is reduced below 45%. Just in case you don't know, a normal echocardiogram will show that the heart is pumping out about 50 to 75% of the blood. So anybody that, in my mind, will document below 50% post-delivery or in the last trimester, to me, would qualify as a postpartum cardiomyopathy. Fortunately, it's pretty rare. It's 1 in 4,000 deliveries here in the U.S. 60% present in the first 2 months postpartum. There is a lot higher incidence in other places like Haiti. I would suspect that if you go to the county hospital like Parkland, where I was, we saw a lot more consults. I spent a lot of time in OB there. Here, half you guys here I never see, fortunately. So it's a pretty rare thing, which probably has something to say about pre-pregnancy management and seeing the doctors and things. Up to 7% may present in the last trimester of pregnancy. Like I said, there's other areas of the world that show this at much higher incidence than we do here in the United States. Unfortunately, we don't know what causes it. There's multiple thoughts. Nobody really knows. Some of it could be nutritional. I doubt this, but some think it might be a small vessel coronary artery abnormalities. There's a lot of new data coming out about maybe prolactin's doing this. Toxemia. There's some thought that it's the mother's immune response causing it. It could be familial, meaning that the family itself has a history of cardiomyopathies, and thus they're genetically prone to it. And then there's other studies now looking at tumor necrosis factor or interleukins or even the APOs. These are all just kind of enzymatic things, but again, none of this is concrete by any means. Nobody really knows at all what causes it. The groups that are more prone to it are mothers that are greater than the age of 30, multiple kids, twins. This may be more of a socioeconomic issue where they're just not getting the pre-pregnancy care like they should. Hypertension and eclamptic patients, nutritional deficiencies, and then any type of drug use might predispose the patients to this syndrome. So the actual criteria is development of a cardiac failure in the last month of pregnancy or within 5 months after delivery. So there's a 6-month window where this generally will occur. You know, if someone came in 6 months post-delivery with it, I mean, obviously you're not going to say it's still going to be included, but that's generally the definition. Again, there's no identifiable cause. So you look for multiple things, which I'll get into how we look into it and see. They obviously can't have heart disease prior, so they can't have a history of cardiomyopathy, other issues. And then the basic criteria is all based on the echocardiogram. You get a sonogram of the heart, and if the heart's weak and they're around the delivery time, then you think you have the diagnosis. The symptoms, unfortunately, mimic some of the symptoms that go along with pregnancy. So P&D is where when you try to lay down at night, you feel more short of breath in the supine position. Short of breath on exertion, cough. Orthopnea, same thing, swelling in the legs, abdominal discomfort, and palpitations. I mean, I'm sure you all hear these complaints in the OB ward all the time. So this is a little bit of an issue. The physical exam is where you'll get a lot more of it. We'll get into cardiomegaly here in a little bit. You might hear a gallop, but you might hear a gallop anyway. Women do have a lot more volume when they're pregnant. And so they tend to have gallops and even murmurs when they're pregnant, which may or may not be real. Swelling, if they're eclamptic or anything of that nature. And even JVP can become along in pregnancy. So this is a big issue with it, is that it can be easily be missed and just be assumed to be other issues. Now if you see emboli magnifications, that's a big deal. They are much more prone to clotting. So if they were to have a clotting issue, most of them are going to get an echo anyway if they throw a clot somewhere in the pregnancy time. But this would be a very clear sign that there's something wrong going on, but also pregnancy itself increases your clotting risk. So again, the problem is often it's unrecognized. Unless it's a significant heart failure symptom, they can be easily blown off as to normal pregnancy symptoms. So there's no way to really just tease it out. You just kind of have to see the patient, see if the symptoms suggest that you need to get an echocardiogram to document, is this just normal pregnancy symptoms or is this related to the heart? One of the signs that might give you an indication, again it's fairly non-specific, is fetal growth retardation. Can be a sign that there's something going on with the mother's heart. I don't know enough about the OBs here. I don't see a lot of OB echoes, so I don't know if they would use this as a sign to go get an echocardiogram or not. Again, we don't see many echoes out of the OB department, so some things that you would want to look for if they came in with these symptoms. One, you can consider a chest x-ray. Obviously, radiation exposure is a problem. If they're pregnant themselves, you would see a bigger heart with a lot of fluid in their lungs. This would be suggestive. Most people are not going to opt to do this. You can obviously do an x-ray, obviously, to protect the baby, but in general, you're going to try to avoid this. EKG, there's a lot of non-specific things. They can have ST or T wave changes. They can have atrial ventricular rhythms, conduction effects, all kinds of stuff, even AFib, but also the EKG could be stone cold normal. So these are just non-specific tests that could help you. A chest x-ray would be very helpful, but again, you're probably going to avoid that in most cases unless you really think it's necessary. An echocardiogram is a clear way to diagnosis. You're looking at the left ventricle itself. If you see that it's dilated and it's not pumping as well, that's the clear answer. Generally, they'll get all 4 chambers will dilate. There's a big difference between cardiomyopathies of heart disease where they have heart attacks where it's specifically defined to the left ventricle. When you get these kind of idiopathic or postpartum, then kind of the whole heart itself dilates, so all the chambers will look big. Rarely they can have pericardial effusions. They tend to get a little bit of leakage of their valves just because of the dilation. The heart's pulling the valve leaflets away from each other. Again, the whole key is going to be looking at the ejection fraction and seeing, is it in that normal range or is it reduced? We can estimate now only wedge pressures. This is a kind of sign of your left atrial pressure, or your left atrial pressure, or if they're in heart failure. We don't do that here at the hospital. We do that in my office, so probably not as helpful here. Clearly, if you saw a clot in the left ventricle, it would be a very big dilated heart, the clot, and then, like I said, the chambers can be dilated. Other modalities that can be used but are much more rare is cardiac MRI. Very good test. I mean, you'll definitely get the anatomical definitions you can see, but an echocardiogram itself is just as good. So unless they have some significant obesity or other issues that really don't give you good windows of the echocardiogram, you're probably not going to go to the cardiac MRI. In general, again, you have to rule out what's causing this. So one of the key things would be a heart cath. Now, if they're 20 years old, I'm probably not going to rush them off to the cath lab. So I mean, the likelihood of them having heart disease is low. Now, the group that's higher risk is the ones that are over 30. So if you had a 40, 50-year-old female that was delivering, okay, could it be? Sure. So you'd want to have to do probably some type of imaging or cardiac cath to look to see if the right and left coronary system is normal. You'd obviously have to pay real close attention to fetal shielding, but this is the key: is it really necessary? Do you want to expose the female? Now, post-delivery obviously wouldn't be as much of an issue, but if they're still pregnant, I'd probably lean on caution side unless they just had a lot of risk factors. You know, 45-year-old diabetic, probably going to have to go take them to the cath lab and see, mainly just to rule out any type of clogged arteries. Women also are much higher risk when they're pregnant to dissections. So the coronary arteries are much more prone to dissections, and that can lead to a ischemic cardiomyopathy, just as if you had plaque built up. So, but they're generally going to present with more symptoms. They're going to come in with chest pain and type of an acute MI process. We used to do a lot of myocardial biopsies. This was to basically rule out any type of infection of the muscle of itself, of the heart. You know, again, it's exposure to radiation, it's a procedure, and the yield is usually very low, meaning the pathologist will look at it unless they truly are in the active phase of the infection. You're not going to catch it, and since the symptoms themselves, you know, generally mask with normal pregnancy symptoms, we don't catch them usually in that quick onset of this. So they usually have had it for a while. So going in and taking a sample of the right ventricle and sending it to pathology is so unyielding that I don't even think of at Southwestern we were doing it. We would just generally rule out heart disease itself as far as clogged arteries, and then just assume that something happened to the heart, but not go for the biopsy. It's a fairly low risk procedure, but still, it's got some risk. So basically, you just got to rule out everything. You can't really rule out an idiopathic family cardiomyopathy or familiar. You have to kind of talk to them about how their family history is. Idiopathic kind of goes back to we don't know what it is. Obviously, if they had HIV, that might be something pretty easy to detect, and I suspect most women are screened for that anyway. The echocardiogram will rule out any type of valve problem. It will rule out any holes in the heart between the atrium or the ventricles. A PDA, if you all know what that is, patent ductus. Okay, this would be clear on exam. If you can't hear PDA, you're not using your stethoscope. So if you would know this one right away just by listening to them. Hypertensive heart disease, obviously these are people that have had a lot of history of high blood pressure uncontrolled that show up at the last minute in pregnancy. They generally have thicker hearts, so a lot of times we can pick that out just by looking at the echo because the muscle will be really thick dealing with blood pressure. This is where the heart cath comes in, looking for a dissection, coronary disease, and embolus to a certain part of the heart because again their clotting risk is up. Spasm's hard. You can see it on cath, but they have to actually spasm in front of you. So unless they don't spasm in front of you, you won't see it. And again, looking for clotting risk. Pulmonary emboli generally will cause these type of syndromes, but you're going to see a lot more strain on the right ventricle because that's what's leading to the lungs. But essentially, we get called more or less to go through this and see if we can find out anything else that might be causing. And you know, fortunately, an echocardiogram and your pre-screening and echo is going to roll out basically down here right quick, and you can even roll out an embolus on an echo. Pretty much you'll be able to tell if there's a look of a pulmonary emboli type process or not. This is always going to be the question: do you take them to the cath lab or not? Usually we get involved. You're going to have anybody that's got these type of problems and needs a high risk OB. Delaney definitely would want to be involved in these type of cases. It's just so we can work together to kind of manage what's going to go on, especially if they're still pregnant. If they're post-delivery, then more or less it's going to fall back to us. As far as anesthesia, generally you want to do more of a spinal. You don't want to give them a regular sedation just because it can depress the myocardial system and make any type of heart failure symptoms worse. So what do you do with them? If you don't spend a lot of time in our world, it's basically you treat them just as if any other heart failure patient. And until we define what actually is the etiology of this, it's going to be management by general medications that we use in typical congestive heart failure patients. You salt restrict them. I go more than this. I'm more of a 2 gram per day type of guy. Water restriction, you really have to limit their fluid intake. You have to give them some diuretics. Nitrates I don't use too often, but the diuretics I will use to reduce the fluid amount or congestion in the heart itself. You want to afterload reduce them. This is a problem, as one of our main agents, an ACE inhibitor or ARBs, are very contraindicated. They're very damaging to the baby. So if they're still pregnant, we can't even go there. It is generally thought that the ACE inhibitors are safe for breastfeeding, not the ARBs. I should have separated that out, but you can use this post-delivery to help out the pregnant female. If they're still pregnant, you can use hydralazine or nitrates or amlodipine, other things to reduce their resistance in their blood vessel system or blood pressure to help the heart beat easier. This would be more or less if they're in the very acute 6-6 phase, which I doubt we're going to see here, but if they're really ill, then you would want to use inotropics to try to increase their pump to help them get through the pregnancy. Digoxin to me is not one I use a lot in pregnancy, but can be used. Beta blockers are the key. These are the type of agents like Corig that are known, the best agents we've got to repair the heart. So this is going to be the frontline therapy. It can cause some growth retardation. Unfortunately, again, it's usually in the last trimester that they present, so not as much of an issue. And then all of them you would want to look into potentially thinking about anticoagulating them, especially if you saw clot potential, but it's not universal. You don't just anticoagulate all of them. If they're really, really ill, really, really weak hearts, especially if you see any type of thrombus in the heart, they're going to be anticoagulated. But a lot of them present with some mild weakness. Those I would not anticoagulate. I would put them on beta blockers, post-delivery, put them on an ACE inhibitor. Again, in pregnancy, use these agents, and then the diuretics play a key role, more or less just to get the symptoms. Decongest them so they can breathe easier and get around. There is some concept about immunosuppressing them. Really, this is for people that have proven myocarditis, and this is just an infection of the muscle wall itself. But again, we don't even do biopsies anymore. The yield was so low that this is really not going to ever probably take off, because unless you're doing biopsies and all of them, you're not going to know it, or if you're doing cardiac MRIs, and they've really just lost flavor to do any of this. You're putting the females through procedures that really have a low yield, and using a potential therapy that we don't even know if it works. This is all with the theory that the mother's antigens are attacking itself and causing the problem. So you could go this route, but it's really not much use. The beta blockers, ACE inhibitors do such a good job that we don't go this way unless they were just really ill. These are the type of people that you're going to start thinking about this when they're severely weakened and they're not getting better, they're in the ICU, they're probably heading towards even consideration for transplant, where you'll start pulling these type of things out. There's a couple of other agents on the horizon that no one uses at this point, but this one I can never say. This one is a tumor necrosis factor suppressor. There's one small study out there that looked at it. I don't read all this because it's going to, I'll give you the general summary, is that in a very small group of people, I think it was 59 women, they tried it. They had some improvement in their heart function post. And all you're doing is blocking the tumor necrosis factor, which is thought to play a role. Again, with the study of just 59 women, there's not enough out there to really make this a frontline therapy. There's no recommendations, but something that's intriguing that might be coming down the line. There's actually better data for bromocriptine. This blocks prolactin. There's been a lot more data lately about prolactin potentially being a cause. And by blocking it with bromocriptine, it could also be one that might help. Again, this is not a frontline therapy, not recommended at this point, but intriguing in the sense that it might be some option to treat these ladies down the road. You won't see it from me anytime soon, because we just don't see that type of women here. If they're very ill, they're going to be, you can put them on an aortic boom pump. I mean, these are all things you can do to help continue to keep the female going, at least until the baby's delivered or even post. I know we had one at Parkland when I left, and she ended up getting a transplant. So what happens if they don't improve? So basically, the new rule is that you have to kind of put them on therapy. So a therapy would, the ideal therapy would include diuretics, beta blockers, and ACE inhibitors. So post-delivery, if you can get them on ideal therapy, you follow them. It's a 90-day rule. It says 6 months, but now it's 90 days. If you follow them for 90 days and you see no improvement, their heart function is still very, very weak, less than 35%, then unfortunately these people are going to get pacemakers with defibrillators, which has actually been shown to significantly help improve systolic function or the heart function itself. And then you're also worried because these are the type of people that die of VT or VF, and the defibrillator would correct that. But again, you have to wait 90 days. There is now a wearable defibrillator that if you're really concerned about the females, you can put a vest on that will defibrillate them if needed. So these would be women that are post-delivery showing a lot of BT or non-sustained VTAC on telemetry. You put them on a vest monitor for 90 days. Even if they're showing it in the hospital, you can't put the defibrillator in until they give them the 90 days. So they wear the vest, and after 6 months, if they're not better, then you put the defibrillator in. And then heart transplantation is for the ones that don't improve. Unfortunately, it's not as effective in these women. For whatever reason, they have a much higher rejection level than a typical heart transplant patient. But these are people that you've done everything. These are 90 days post, you put a defibrillator in, they're just not getting better, they're getting worse. They continue to have heart failure symptoms, admissions for heart failure. They're just not improving on ideal medical therapy, defibrillators, and then this would be the group that you would consider a heart transplant on. Prognostically, about a third of these women quickly recover. So fortunately, there's about 30%. You'll see them, you'll get them on the right meds. 3 to 6 months later, they come back to the clinic, you've got an echocardiogram, and they're returned back to normal. The question with those ladies is, what do you do about the medications? No one knows. I mean, do you keep them on these meds the rest of their life? Do you stop them? No one's ever done any type of research to see, once they get better, can you stop everything? It was just a kind of a quick transient drop that went and recovered. So you kind of have to just see. A lot of them are young women with low blood pressure, so these medications are hard on them. So you kind of have to just follow and just do it. If I stop the medications, I'll usually re-follow up with another echo to make sure they're not going the wrong direction. If I think they're higher risk individuals, I'll keep them on it, but there's really no way to know. This is kind of roughly about a third develop the heart failure, and they'll just kind of keep a weaker heart, and they just stay that way, but they do pretty well. And then there's a third about that just kind of continually deteriorate and head more towards the defibrillator and the transplant type things that we talked about. Usual death in them, this is that last third group is continued heart failure, arrhythmias. But again, this is less of an issue because most of them are going to get defibrillators 90 days later. These are just kind of prognostically, the initial high-risk period with mortality of the 25 to 50% is in the first 3 months. So I mean, the ones that do bad quickly, and you'll know it. Once they kind of stabilize, like the lady we had in 2 North, she actually did really well. She was pretty easy to treat. They have persistent large hearts. Going down the line about what do you do with these people if they recover, if they want to have a pregnancy again, you're usually going to tell them that it's not a good idea. Because if the heart had a weak spell at once and you got lucky and it recovered, you just don't want to take that risk again. I know we had a couple in Parkland I followed that actually insisted on pregnancy again and did fine, but I mean the risk is that they're going to potentially relapse. If they relapse, you keep teasing the heart, eventually it may not recover, so you're just going to recommend against it. And obviously it's easy for us to say it, but for the women, you just have to kind of sit down and just go over the risk for them. The groups that tend to do poorly down the road are the older groups or have a lot of kiddos. And then the ones that have a later onset, and then the ones that you usually can tell right away when you look at the echo. I mean, if their heart function is 10–20%, they're very symptomatic. These are the ones who are not going to do well. The lady we had on the floor, her heart function was in the 40–45% range. It wasn't that bad, so they're the ones that quickly usually rebound. So the main points to remember, I told you them pretty short, is that the hard part is diagnostically. They have a lot of the same symptoms that a typical pregnancy would, so you'd have to be really astute to look for certain things that might trip you over to say that this is somebody we need to consider as a potential heart failure patient. This again may lead to some of it, as far as if you see a lot of symptoms and fetal growth retardation, maybe thinking about, do we look at this to make sure it's not heart failure? We treat them just like any other cardiac patient that's in the heart failure clinic. Same drugs that we use as the 80-year-old heart failure. It's the same treatments. Epidurals are the key when you deliver, and advice against subsequent pregnancies.
What do you use for the anticoagulant?
In pregnancy or post?
Post.
Post is regular Coumadin. You heparinize them if you need it acutely in Coumadin. During pregnancy, it depends on what stage they are. But post-pregnancy, it's just typical stuff. You can't use any of the new agents that I know of. I guess you could, but they haven't been studied in the type of women. I'd be very skeptical of the newer agents if they're breastfeeding too. Come in and safe if they're breastfeeding. If they're very sick, you're going to do more of an urgent delivery. This would be something I'd leave to Delaney to decide. I would just keep managing and let her pick that. Breastfeeding is okay if they're clinically stable. Obviously, if they're in the ICU, that's not going to happen. But if they're a very low level, like the lady we had, and they're stable, there's no issues with breastfeeding. If they're breastfeeding, you can't use the ARB class of drugs, like Diovan and things, but you can use the ACE inhibitor class. Should have no effect. That's pretty much it. Like I said, it's a very simple disease in the sense is that we just don't know a lot, so there's not a lot to talk about. It's just an unexplained weakening of the heart post-delivery or in the last trimester that you get. Usually then they come to us, we treat them and just follow them and see if hopefully they can cross our fingers that they get better. Questions?
Question.
Yes, ma'am.
So the women that recover from this, are they later years down the road, or are they more predisposed to
Not
heart
that,
failure?
nothing's been done to suggest anything of that nature. That it's kind of like a viral cardiomyopathy. When they get sick, get weak, they come back. There's no thought that they're going to have it, or these type of people are going to have any recurrence or higher risk of having it. Like I said, the harder part is to know what to do with the drugs, you know, because you don't want to be the, you don't want to stop them, and then they go back the wrong way. Then you're, so that's the harder decision to make on these people. And then committing a 20, 30-year-old female to drugs the rest of her life is not ideal either. So that's the big problem.
The 90-day, the reason to wait for the 90 days, is that mostly for like homeostasis, the volume to return to normal, preload?
It's a Medicare rule, but in general, most of us agree with it because ideally what was happening, really it was just a cost issue, is everybody was slamming defibrillators in these people right away. And this is more in the typical heart failure, the 70-year-old with heart attack type problem, is they come in, heart weak, defibrillator. So the 90-day rule, because a lot of these people were getting better once they got on medical therapy and then having defibrillator for the rest of their life they didn't really need. So the 90-day rule really didn't stem from women. It came from the, you know, the older population with heart failures type symptoms that the meds work, you just got to give it time. It was always kind of risky because you're sending somebody out with bad hearts for 90 days hoping they don't die on you, but now with the wearable vest, we don't use them often, but you feel a little more comfortable about sending some of these people home that you typically would have put a defibrillator.
The patient that was on 2 North, do you recall the specifics of her case? I'm not familiar with when it developed.
I just remember she didn't have a lot of prenatal care and post-delivery. She was just short of breath, a little puffy in her ankles, and someone got an echo, and if I remember right, her EF was about 45%. We got her on a beta blocker. I don't think I used an ACE inhibitor on her. She had real low blood pressure, and again, I don't think she followed up with me to repeat the echo.
Was she diagnosed in a week no beat here, or did she go home and come back? Anybody remember that?
I think she came through the ER and got admitted to North. Yeah. So she went home, came back with heart failure symptoms, and got an echo by one of the medicine docs. Yes, ma'am.
So is C-section indicated for these patients that show up with these symptoms prior to delivery, or is it safe for them to labor?
If they're fairly low level, mild weakening, I would, you know, again, I'd leave this to Delaney, but those I'd be okay with. But if they're any advanced heart failure at all, they're all going to get C-sections. Just you have more control.
Yeah.
But I mean, if they're kind of like that lady was, she was not that hard to treat. You know, she was post, but I mean, she was still pregnant. I wouldn't mind letting her go. You know, fortunately, we have good OBs here, so and good anesthesia, so we'd be all right. But obviously, anybody with advanced failure in the unit, you know, if the weak heart, if I had to guess, I mean, I would probably gauge anybody in the moderate to severe. I'd be more reluctant to vaginal delivery. If they're mildly weak, then I'd probably be okay with it.
Do you know, did she have a vaginal delivery, or was she a section?
No idea. Not the type of questions I usually ask.
I think she had a C-section.
Yeah, I think she did.
She did what?
I think she had a C-section.
Any other questions? Like I said, it's pretty easy because fortunately we just don't know a lot about it. It's just rare enough that it's just out there. The harder part's for the docs to figure out who to pick up on and go and do an echo. I'm sure there's a lot of women that come in with vague symptoms and they have some mild weakening that we miss. I mean, I'm sure it's very common. The very severe ones you're going to know, but the mild ones I bet we miss a bunch. And fortunately, a lot of them probably get better on their own once they deliver, but and then later, if not, like her, they present short of breath, swollen post-delivery, then that would probably trip somebody's, brain to say, wait a minute, here's something else is going on. Okay?
Thank you.
Thank